Today I have the great pleasure of introducing Dr. Perry Hsu, my new partner. He did his fellowship here with us at Northwestern University, and he specializes in complex kidney stone disease as well as HOLEP. He came to us by way of UC Irvine, where he studied with Ralph Klayman and Jamie Landman as a resident, and now he's here with us on staff. He's very talented, has a strong research repertoire, and strong clinical background. And today he is going to speak to us on, what are you speaking to us on, Dr. Hsu?
Updates in endourology equipment. Thanks so much. So thanks so much for the opportunity to present. My name is Perry. I'm an assistant professor here at Northwestern Medicine, and I'll be talking about the updates in endourology equipment. I have no financial disclosures. I want to start with a note on innovation in endourology. So we as endourologists treat very tangible disease processes with significant and increasing prevalence. Kidney stones affect 1 in 10 Americans, and BPH is always affecting more and more men as we get older. So we as urologists tend to have a reputation for being creative and innovative and embracing new technologies to help treat our patients. But this rapid pace of innovation can definitely be at times overwhelming. As you can see, we love our acronyms. So my job today is to talk about some basics about our existing endourological equipment and the reason why we keep making newer equipment, and ultimately whether or not this new equipment has significant clinical benefit. So in outline, we'll be talking about lasers, a little bit about laser physics, because you got to understand a little bit of that to really understand the innovations within our laser equipment. We'll talk about ureteroscopic equipment and changes and new things, some brief discussion on PCNL equipment and non-invasive stone treatment equipment, and then finally some talks about benign prostatic hyperplasia treatment equipment. Less focus on missed treatments, more so a little bit on what's on the horizon. So laser equipment. Let's just talk about lasers. Funny enough, laser is also an acronym, so it stands for light amplification by stimulated emission of radiation. Lasers were first invented by Theodore Maiman back in 1960, and we've really adopted it within our urologic world. So we have used diode lasers, potassium titanal phosphate lasers, also known as green light lasers, neodymium lasers or Nd:YAG, holmium lasers, which is actually a holmium YAG crystal doped in holmium. There's also a thulium fiber laser and also thulium YAG lasers. So urologic lasers have been really chosen for their properties to help perform minimally invasive surgery. I'll highlight 3 of our lasers that we use in the modern day, the holmium, the thulium YAG, and the thulium fiber lasers. These lasers emit wavelengths near infrared, and they are able to be transmitted through an optical silica fiber, which is why when we use our laser fibers for our urological surgeries, we can use a flexible laser fiber to really achieve the goal of doing endoscopic surgery well. So let's talk about lasers in general. What is our wish list as endourologists? What would we like to see in our lasers? Well, we want to see easy to use lasers, durable lasers, affordable lasers, lasers that are precise with less brick propulsion. You want efficient lasers, lasers that can achieve what we want to do, which is treat BPH and kidney stones. So you want to be able to have that versatility, you want to achieve excellent hemostasis, and you also define and separate tissue planes. But before we get to how the innovations within laser technology is helping us achieve our wish list, I'll talk a little bit about lasers and how they work and the general principle. So one of the first lasers that we used in urology is the holmium YAG laser, which we just all refer to now as the holmium laser. The YAG stands for yttrium aluminum garnet, so it's a crystal actually, and then we dope it with holmium ions. Holmium is on the periodic table. I had to check myself. It's element number 67. It's part of the lanthanides group. So the YAG crystal is doped with holmium ions, and then uh, it's activated and the photons are jumping and then back down, and then they're stimulated and ultimately radiate energy at a 2100 to 2140 nanometer wavelength. And that's on the electromagnetic spectrum. It's near infrared, so you can't see it with your naked eye. It is a pulsed laser, meaning the laser shoots energy in pulses. It's not a constant energy delivery. It's mostly absorbed by water, and because of that, it has a very low penetration depth within tissue of only 0.4 to 0.5 millimeters. So, wanted to reiterate exactly what light lasers are. Light amplification by stimulated emission of radiation. So here's a schematic. Imagine you have energy, you put that energy onto a YAG crystal that has holmium ions. The atoms are excited, and then they jump back down, and the photons are emitted at a specific wavelength that is dependent on whether or not you choose a holmium YAG crystal or whichever laser medium, and then it's focused into a laser beam that we can transmit it down a flexible silicone laser fiber and do our surgeries. So that's how lasers generally work. Nowadays, we have even higher power lasers. So when you hear about, oh, you have a 120 watt laser, you're talking about the average power emitted by a laser. So we, instead of having lower power lasers, we have higher power lasers. What does that achieve for us, and how do we get that? Well, if you have a low power generator and you stack them, then you can get a higher power generator. But that creates a louder, hotter, bulkier laser. You need to have a special power outlet that your operating room might not be fitted for. But we have shown that a higher average power allows for faster, efficient surgery and lower operative room times. Not necessarily different in stone-free rates, but definitely faster and more efficient. But even though I went over how lasers work overall, we actually need to understand how lasers laze in even more detail to actually truly appreciate the new modern innovations in laser technology. So I said earlier, lasers deliver energy in pulses, at least our holmium laser does, and that means that the energy is delivered in discrete packets per pulse, and each pulse can actually have a different duration or width to deliver the energy. So it's and that brings into the concept of average power versus peak power. You can have and I'll look at this graph right here. Average power is energy times frequency, the settings on a laser that we're very familiar with. But if you bring into the concept of pulse width or duration, then you can actually calculate peak power, which is energy divided by your pulse duration. So even if you have a very low average power, you can actually really achieve a very high peak power if you have a short pulse duration. So the laser settings that we're familiar with are energy and frequency. How much energy do you confer per pulse, and how many pulses per second? But now there's such thing as pulse modulation. You can look at the pulse width, you can split the pulse, and you can actually change the shape of pulses. So the analogy is this: if, let's say, you have 1 second to push someone from from one side to off of a cliff, do you push them right away and then wait 9/10 of a second later, or do you take your entire second to push them over? That's kind of what pulse width really is and what it represents. So that brings me to your stone settings and what your laser settings and what you would want for certain things. So if you are trying to break a stone in pieces, then you really want high energy, low frequency, and a short pulse width. If you're trying to dust a stone, then you want a low energy, a high frequency, and a long pulse width. So this is the concept of pulse modulation. This is why we need to know the laser physics a little bit to understand what is going on with these newer lasers and what really makes them do what they can do to help us operate and be better endourologists. So there was a great systematic review published very recently by the European Association of Urology, and this kind of denotes the timeline of evolution of pulse modulation technology. the first holmium laser application was in 1992, but then all the way up into 2017, there was this concept of MOSES technology that was invented, and then in 2020, there was this MOSES 2.0, and now there's even more and more and more lasers out there. So I'll go over that. So what is MOSES technology? Well, I told you lasers can have pulses. That is, those pulses can actually be split. I told you that lasers are, at least holmium lasers, are majority absorbed by water. So if you have energy from a holmium laser put into fluid, then it will actually evaporate the water and create a bubble. If you split a pulse, then you can actually put one bubble out, and then it'll create a bubble. Put one half of the pulse out and create a bubble, and then you can deliver a second part of that pulse to whatever you're targeting. So that's called the MOSES effect. So that really allows us to actually enhance your efficiency of what and hit whatever is behind it by splitting that pulse and causing this double bubble effect. This was first invented in 2017 by Luminous for MOSES technology. It's called MOSES technology because you part the waters and then you send your second energy out there. And in 2020, they created the MOSES 2.0 effect. But other companies have also had their own version of this. So they have a bunch of different names out there which you may have come across. The vapor tunnel, the virtual basket, the bubble blast, the advanced mode, stabilization mode. So these are all different ways of how laser technologies have advanced over time and changed in our equipment, is with pulse modulation. So I have a little graphic here from the Quanta group where they demonstrate what the difference is between a normal pulse and then also what they call a virtual basket, where they split the pulse in a certain way, and a vapor tunnel, where they actually shape the pulse and split the pulse in a different way too. So the desired effects is that you can actually increase goals of reducing rich repulsion, as well as perhaps even creating a shockwave-like effect, depending on what your goal is with these lasers. We employ the MOSES 2.0 laser here, and these are some pictures that I grabbed from the operating room of just modulating the lasers. So these are the settings. You have the common setting of changing your energy. You can also change your frequency, but then there are these other new settings, which is the MOSES effect, which you can choose whether or not you want to split your pulse in half at either a contact or a distance setting, which is proprietary information on how they split and create their bubbles, or you can modify your pulse width. You can have a short, medium, or a long. Again, short means that you would have a higher peak power. Long meaning you would have a lower peak power. Short you would choose for trying to crack or break something. Long would be if you wanted less retropulsion. And this is for high power holmium technology. So pulse modulation, this is a graphic on MOSES distance versus MOSES contact. Exactly how did they change the energy delivery? How did they split it to achieve an effect within water and create these bubbles? So what is the clinical evidence for pulse modulation? I referred to the systematic review published very recently titled, "Is Pulse Modulation the Future of Laser Technology and Endourology? Evidence from a Literature Review." So they looked at all the clinical studies available at the time for pulse modulation, and then they ultimately determined that for stone disease, there is limited evidence to show that this is with significant benefit. There are a bunch of different outcomes, but ultimately the jury's still out. We have found some significant benefit for pulse modulation for performing holmium laser enucleation in the prostate, but there have been also mixed results across the board on whether or not the MOSES technology for holmium laser enucleation in the prostate ultimately yields significant clinical outcome differences. But we have had significant benefit from the holmium laser, high-powered holmium laser with MOSES technology for achieving same-day discharge. Just a little just to throw it out there, we are doing an ongoing randomized control trial here at Northwestern looking at ureteroscopy with high-powered holmium laser with Moses 2.0 on or off, and we are currently recruiting and excited about ongoing data. So that brings me to updates, the original intention of this talk, which is updates in laser equipment. So I wanted to bring attention to a new laser out there. There's the Cyber Holmium Magneto 150 watt, marketed by Quanta. So this laser is different because it gives you a much longer pulse duration option. You can increase your pulse duration all the way up to 2,000 microseconds, which provides a potential reduction in your peak power down to 500 watts, which is very similar to a thulium fiber laser. So just to bring things to reference, your typical pulse duration for a high-powered holmium laser is 150 microseconds to 1200 microseconds. For reference, most high-powered holmium lasers usually have a peak power within the kilowatt range. So this magneto laser really kind of allows us to recognize the benefits of lower peak powers, which is going to result in less retropulsion, better dusting, theoretically. So that brings me to thulium fiber lasers. Thulium fiber lasers are very different than holmium YAG lasers because thulium fiber lasers are not actually a solid like crystal. It's the fiber itself that is doped with thulium ions, which are also an element on the periodic table, part of the same lanthanides group. The difference for thulium lasers is that their wavelength is closer to around 1900, which is very, very close to the absorption for water. So it's much more heat efficient, and it can be done at much higher frequencies, and as a result, also lower energies. The difference, though, is that the peak power is a lot lower because the pulse duration is and the pulse width is significantly longer. As you can see here on this graph on the right, the peak power watt-wise of a thulium fiber laser is usually only up to 500 watts. So the pros of a thulium fiber laser is that they can be as small, the fibers themselves can be as small as 50 micrometers, and that would increase your flow and deflection during your uteroscopy. The laser itself can be plugged into a wall, so that's great for us because it's portable, it's quiet, it's less hot, and you can again achieve these really high frequencies, and these pulse durations can again be from very, very able to be modulated. Oftentimes now you'll see a thulium fiber laser as being quote unquote super pulsed, and that's meaning that they have all these options of being able to deliver really concentrated bursts of energy in a very short time frame, which is an attempt to try to increase the peak power on thulium fiber lasers. So when thulium fiber lasers came around, there was actually a recall, class 2 device recall, where there were 28 complaints, which was a result of some very complex, very unfortunate injuries of the ureter, likely due to not knowing exactly which laser settings to use for a thulium fiber laser. I mentioned that the thulium fiber laser has lower peak power, but that means that it's really hard to actually break apart stones and fragment them like the classic way that the holmium laser does. So there's a very significant difference in the way that a thulium fiber laser actually behaves. So if you put your foot on the pedal on a thulium fiber laser to try to fragment and break apart a stone, you actually probably won't break it apart just because the thulium fiber laser, it has an innate lower peak power and it won't actually be able to break apart the stone the way you desire. So a note on that, the lasers that we use can definitely heat things up. If you put your foot on the laser and you cause the temperature to increase significantly, you can start to have tissue damage. It usually starts at about 43 degrees Celsius is when tissue damage actually starts to occur, and tissue necrosis actually begins around 54 degrees Celsius. So there's is a nice in vitro study where they used both thulium fiber laser as well as the holmium YAG laser, and they use basically 200 micron fiber at 0.2 joules and 40 hertz for an average power of 8 watts, and they put their foot on the pedal for 60 seconds, and they noticed that there can be a degree increase in the temperature of up to 15 degrees Celsius from 37 degrees Celsius after 60 seconds of continuous firing in a closed system. The good news is that irrigation really helped out. If you, instead of having a closed system, have flow in, flow out at different rates, you can really prevent that temperature rise. And they were able to demonstrate that in a vitro setting too. I bring this up because we have a little sneak peek of an AUA presentation. We looked at 6,726 patients who underwent holmium laser lithotripsy with high-powered holmium lasers in about 93% of the cases versus TFL lasers in 548 patients, and we were looking at stricture rates post-ureteroscopy. And we did identify that thulium fiber lasers had a significant increase in stricture rates compared to those who underwent holmium laser lithotripsy for ureteroscopy. So that really brings attention to knowing your lasers, and maybe this was part of the learning curve for the adoption of thulium fiber lasers and not knowing that peak power made such a difference. But I want to bring attention to some very recently published randomized control trials comparing holmium YAG lasers to the thulium fiber lasers. The first one was published by Dr. Nakata's group, looking at 108 patients, 52 to holmium, 56 to thulium fiber. Laser times were pretty similar. Nobody used any ureteral access sheaths. There were no second guide wires, and all patients were stented. The stone-free rate was determined by KEB or ultrasound 4 to 8 weeks post-stent removal, and they looked at absolute stone-free rate, and they found that they were actually pretty comparable, 68% versus 67%. So what was their conclusion from the study? Well, with similar clinical effectiveness, pulse-modulated holmium YAG lasers and TFL laser selections can really just be based on institution or surgeon preference. So based on the way that they did their ureteroscopy, there was no difference whether or not you used a TFL laser or a high-powered holmium laser. The next one would be by Dr. Gupta's group, Mount Sinai. They looked, and this was published, it's in press, it's going to be released in the March Journal of Urology edition. They looked at 66 patients, 33 to holmium, 33 to TFL, and they looked at absolute stone-free rate as well, and it was 79% versus 82% based on CT scan post-op 6 weeks. There was no difference in laser energy, time, ablation efficiency, and speed. They had similar complication rates. Only 50% of their patients in both arms got stented. They also did not use any access sheaths. They used gravity irrigation. Their mean OR time was 50 minutes for about both. Mean laser time was about 20 minutes for both. They used the Storz FlexXC scope for both arms. And their conclusion was similar. We found the pulse-modulated holmium YAG laser and the super-pulsed thulium fiber laser to be equally safe and effective, and the laser choice should be up to the discretion of the surgeon. So I finally, in terms of lasers, want to talk about the thulium YAG laser. Very often you'll hear, oh, I used a thulium laser, but they're referring to a thulium fiber laser the majority of the time. Thulium YAG is different. It's a YAG crystal doped in thulium ions, and then it's excited and then creates energy. And it actually creates energy at a different wavelength. It creates energy at a wavelength of 2013, which is nanometers, which is closer to the 2120 nanometers for holmium lasers as opposed to the thulium fiber laser. So it's a little less absorbed by water, but it's not exactly the same as a holmium either. There's a study in 2023 in the World Journal that looked at thulium YAG lasers, and they really found that there was less retropulsion compared to the holmium YAG laser, but it wasn't exactly the same as TFL either. There was a higher peak power for the thulium YAG laser compared to TFL, but it's also lower than holmium YAG lasers. So I'm very excited to see what the clinical niche of this laser really will be in the future. So laser settings wise, just to bring attention to this, is the settings are not all equal. You know, we talked about how thulium fiber lasers have lower peak power. So as a result, when you're doing a thulium fiber laser and you want to use, you want to do it to the max efficiency, you actually probably want a short pulse to actually achieve higher peak power than you can. Short pulse for TFL does not equal short pulse for holmium YAG lasers. They have different settings, they're very different, and that's something just to keep in mind. So, laser equipment updates. There's a lot of lasers out there. There's holmium lasers, there's thulium fiber lasers, there's thulium YAG lasers. More and more people are finding out things about lasers and how to modulate them, how to change the pulse, how the actual energy is being delivered. So there's a lot more settings and more control and more customizability. There's a lot of fine tuning. So we want the best of both worlds. You want a laser that can fragment and dust for stone disease, and you want a laser that can have a shockwave effect for tissue dissection, and also hemostasis and coagulation for prostate enucleation. So this is a very ripe area for research and optimization. We don't know what we don't know about lasers and what could be next. So you really have to learn your laser, and if you do, and you know how to use it, you can use it well, and it's probably not going to be significantly different from the other ones, but as long as you know all the properties and the safety profiles. So that finally brings me to your ureteroscopy equipment. So we get all these hashtags and acronyms. You have flexible ureteroscopy, you have fans, discs, sure. So we'll try to talk about these. So our ureteroscopy wish list. You want a clear visualization. You want to be able to see well. You want good ergonomics. You want durability, reliability. You want to be able to reach the hard places. And you probably want good flow with a larger working channel. So when we talk about flexible ureteroscopy, there's been a whole push to going towards disposable. And you know, there's arguments on both sides regarding the climate consciousness of this. There have been cost analyses that kind of show that if you do a lot of ureteroscopies, then the reusable scopes can be beneficial, but if you use them seldom, then perhaps the disposable ones would be better because you don't have to pay for the maintenance and the repair costs, which can be very costly for reusable scopes. So, you know, but there's been this big push towards disposable ureteroscopy and single-use scopes. So I'll try my best to talk about some of the newer upcoming ureter scopes out there. As I had mentioned, lots of different brands, a lot of different ureteroscopes. I'm going to highlight a few of them just to give everybody an idea. One of them I'm going to highlight is one that we use often here at Northwestern with the Flex XC1 from Storz. It has a CMOS chip at the end. It has a 105-degree angle of view, 270-degree deflection up-down. It has a 3.5 inter-channel working channel that comes out at 3 o'clock. There's a tapered distal tip, which I like. But the reason why I'm going to talk about this one is because we did study whether or not the disposable flexible ureteroscopes have a good enough visual quality compared to their fiber optic and digital counterparts. So we administered surveys to endourologists to kind of look at, hey, what do you think? Do you like the fiber optic? Do you like the disposable? Do you like the digital? What are your opinions on the visual quality? And kind of across the board, we found that digital and disposable scopes tend to be reviewed better by endourologists for visual quality. So that's this is the Flex XC1 scope. The next scope that I wanted to kind of touch base on is the Richard Wolf D URS, which has a completely different way of holding it. You actually put your hand in between these two arms right here, and then you can flip up and down to deflect your the end of it. It has a 9 French outer diameter with an atraumatic 6 French tip. There's actually two working channels. There's a laser channel that's 1.65 French, and there's a 3.6 French working channel, and then you also have continuous flow. You can have a lure connection for inflow, and there's outflow available as well. scope has been described as being able to do it all, because you can put it in as a semi-rigid, and then you can also perform flexible ureteroscopy as well. So this is a fun scope that is completely different in how you hold it. Another scope out there is the LithoView Elite scope by Boston Scientific. This scope distinguishes itself from its competition by intrarenal pressure monitoring. It has a similar working channel, 3/6 French, and a similar shaft diameter, 9.5 French, but it really just tries to distinguish itself based on intrarenal pressure data. So when we work with ureteroscopy, there's been some data that shows that intrarenal pressure monitoring can be important for monitoring to make sure there's no pilovenous backflow, increased risk for sepsis, increased risk for pain. There has been, using this scope and using this monitoring, we're able to better identify and discern intrarenal pressure and what can happen. We know that highest pressures are from manual pump irrigations, and placement of ureteral access sheath can actually be protective in reducing intrarenal pressure. The clinical thresholds of intrarenal pressure and also the significance of it, I think, still remains to be determined, but at least now this scope is out there and is able to enable all of this new developing research. I do think a potential development from this technology would be able to develop an intelligent irrigation method so that we can see what type of intrarenal pressure is best for visualization and also safety, and then maybe whether or not this can be programmed or communicated with the irrigation system so that we don't have to worry about pressure, and we don't have to worry about not being able to see. So I think that that's one possible future applicability. Another scope that I wanted to bring attention to is the HugeMed HU30M. This is distinct from its competition because it has the smallest one out there. It's only 6.3 French. Now, the diameter of your ureter is usually around 5 millimeters, so this would be very beneficial because if you have a patient who just has the tightest ureter or has any sort of retroperitoneal fibrosis, something's making it difficult, you can't put up an access sheath if you usually put up an access sheath. Well, this scope, if you have it available, might be able to help improve your primary ureteroscopy success rates. So I'm very excited about the scope. I'm excited to get my hands on the scope and also see what kind of clinical benefit it will bring in the future. And that brings me to suction equipment for endourology equipment. This is really all of the buzz nowadays in the endourology. The first thing I'll talk about is DIS, which stands for direct in-scope suction. So there's the Poussin U-scope, 7.5 French, that actually has an ability to have suction control where you can press this button and you can actually suck directly through the scope out, which you can see here. You can hook it up to a suction tubing in a stone catch canister. So this was evaluated very recently. This is the first clinical evaluation of a flexible digital ureteroscope with direct in-scope suctioning system, the Poussin DIS 7.5 French channel. A prospective multi-center feasibility study. So this is 6 centers, 57 cases. Mean stow volume was about 480 millimeters cubed. 33 out of the 57 were pre-stented. Some limitations is that there was a lot of heterogeneity in your laser settings. There was heterogeneity in ureteral access sheath use. It was about a little more than half the cases. The stone-free rate was done at 5 weeks post-op with imaging of any sort, so KUV, ultrasound, or CT scan, and they did ask surgeons at the conclusion of the case, do you think that this suction device was helpful? And most people did. The mean OR time was 50 minutes, and the mean laser time was 19.5 minutes. So I haven't had the opportunity to try this scope, but it seems like it only helps and enhances with trying to make sure that stones get removed. The next device that I was going to highlight and hashtag that you often will see is SURE, which stands for Steerable Ureteroscopic Renal Evacuation. So this was first kind of noted by the first generation of the CVAC device, which is actually a steerable ureteroscopic evacuator. It's fluoroscopically guided, so you don't have a camera on there, but there was an outer irrigation lumen and inner aspiration lumen, and you would drive this under fluoroscopic guidance into calyces at the conclusion of a case to suck up stone fragments. So, published recently in the journal Endourology last month, it was the prospective randomized non-inferiority study to evaluate the safety and efficacy of SURE compared to standard ureteroscopy, a 30-day result of the Aspire study. So this is 11 sites. They looked at the first generation CVAC fluoro-guided. They randomized 1-to-1 ureteroscopy versus SURE, 55 to 46 patients. All patients had to have a 12 by 14 access sheet placed to qualify, and that's because of the girth of the SURE, the CVAC first generation device. There was differing scopes employed across the sites, and they had different lasers, different lasering settings. Basketing was allowed, and they looked at CT scan post-op at 30 days. So if you look over here, what they really showed was that the stone clearance rate was really quite flat, whether or not you started out with a lot of stone or a little bit of stone. And that was in contrast to the ureteroscopy arm that they looked at, where if you had a really big stone to start with, you were less likely to be stone-free post-ureteroscopy. And that does make sense to me, because a lot of the times when we do ureteroscopy, if it's a very large stone and you're going to have a lot of fragments sometimes and you don't want to basket them all, then maybe an absolute stone-free rate at CT scan post-op 30 days, you might see some residual very small fragments. So now I'll talk about the second generation for CVAC, which is very exciting. This is actually where they incorporated the CVAC device with being able to be driven under vision, so you can actually see. This is similar to the first generation in that the outer diameter will require you to use a 12-14 access sheet to be able to put it up if access sheets are part of your practice. But it was very exciting to see that you could actually use this device and actually see and collect stones. So I'm excited for the future studies on this, but here are two videos from their website that kind of show that this scope, while you're lasering, can have a passive suction, and then when you're concluding lasering, you can actually suck out the fragments with active suction. And they have 4 jets at the end of their scope that can kind of disrupt things and then suck out through the center, which distinguishes itself a little bit from the disc procedure or the direct in-scope suction. So I'm very excited about trialing this device. The next acronym to look at is FANS, Flexible and Navigable Suction Ureteral Access Sheaths. So here's a study. Could use of a flexible and navigable suction ureteral access sheath be a potential game changer in kidney stone surgery? Outcomes at 30 days from a large prospective multi-center study. So this was 25 sites from August 2023 to 2024. Looked at 394 patients, median stone volume of 1,260 millimeters cubed. About half of practitioners used TFL lasers, the other half used holmium lasers. Mean lasing time was about 18 minutes, median OR time 49 minutes. Stone free rate was also assessed with post-op CT scan, so it's the best you can get for stone free assessment. And they looked at absolute stone free rate was 57.4%. Absolute stone free rate plus a small residual fragment less than 2 millimeter was most patients at 97.2%. They looked at 3 different brands of suction ureteral access sheaths. The Elephant brand, which is this one, the Clearpetra, and the Innovex. Here at Northwestern, we have access to the Clearpetra suction ureteral access sheath. So I just want to bring some attention to some of the parts of it. This is it's a ureteral access sheath that's placed the same way as a normal ureteral access sheath, except it has a flexible navigatable tip at the distal segment that you can drive into your calyx of choice. You have a pressure vent at the side of it, which you can control, but then you actually will suction, you'll turn the section on and then drag the scope back until the stone fragments can fly out through this Y branch here. And the red band here denotes that scope withdrawal limit. So here is a picture of it in actual use. You have the access sheet up, you have a suction tubing on the Y aspect, you have a rubber seal on the cap of it to maintain the irrigation in the system, and then you have a separate suction canister that you can modulate and turn on and off. Here's some videos of a case that I did recently where I found a cystic collection of very small stones in someone's kidney, and it would be very tedious to basket every single small one of them. So after I opened up this cyst and all the stones flew out, I then used the suction ureteral access sheath, drove up to the stones, and then directed the sheath in and then sucked them up so that you can actually drag the scope back and all the stones are coming with you. So that was a nice, really improved my time for that day, because I didn't have to spend a lot of time basketing. Instead, I could just suck all these stone fragments out. So now that kind of brings together, you can use fans and modern lasers, and they actually looked at that, and they showed that whether or not you used a thulium fiber laser or the high power holmium laser, you could do it very well with fans and have really high stone free rates of up to 97 and 99%. So I just wanted to bring some attention to some additional ureteroscopic equipment. Something that was very exciting down the line, out at Dr. Liao's group, they did something called the MagStone, where they actually have a hydrogel that magnifies stones, and then they use a magnetic wire, and then they're able to withdraw those stones. So this was recent, and hopefully down the line we'll be able to see this maybe in clinical use. And here's one of their figures showing that you can magnetize stones with their hydrogel, and then you can actually withdraw all the fragments with a magnet guide wire. Another thing that I thought was very interesting and cool is the J-Fill stent. This is a stent that is marketed by Rocamed, and here in the States will be Olympus, but I don't think they're available yet. But they're pigtail suture stents. Instead of having a double J stent, you can have just a single pigtail and then have a suture run down the length of the ureter to maintain patency. And they've shown that this actually significantly reduces symptoms from stents in terms of lower ureteral stent symptom questionnaire scores, as well as lower pain scores. Because of the way the stents are actually made, you can't really use these for distal ureteral stones, because the filament itself, that's what they excluded, because it wouldn't actually have a stent coil or anything in the distal aspect. So that is a limitation of this device, but I'm excited to see where this leads for mitigating stent symptoms moving forward. Another thing I wanted to bring attention to was ureteral access sheaths in general. So I routinely use ureteral access sheaths, but you know, we don't really scientifically place the ureteral access sheath without, in the sense of knowing how much to push. So there's been a lot of research done out at UC Irvine and in their group to find out exactly how much force can you use. And this is an invention that they noted as the Air Force One, where they basically showed that if you used a 1 cc syringe, you can actually track how much force you're using to push up a ureteral access sheath. And if you push up to basically the entire 1 cc syringe, then you can actually push it too hard. We should stay under 6 newtons of force when you want to place a ureteral access sheath. So this is one way to scientifically do that, and I think that's a cool up-and-coming device, particularly for education, I foresee. So this finally brings me to PCNL equipment. PCNL wish list. When we do PCNLs, you want good ergonomics, you want less fluoro, you want a cheap and easy setup, you want perfect access, easy access, and it's really kind of all about access. So what are some new updates in this technology? So the first thing I want to talk about is ultrasound. We typically achieve PCNL access on our own with either fluoroscopy or ultrasound guidance, but sometimes you have an ultrasound and you put the ultrasound on and you realize your system that you're trying to poke into is not dilated at all. Well, they actually have invented something called SonoView, which is basically an ultrasound contrast that when you put an ultrasound on it, it kind of highlights the system. So there's this comparison and contrast comparison of contrast enhanced ultrasound versus conventional ultrasound guidance for percutaneous nephrotomy and non-dilated collecting systems. It's a systematic review, and they showed that if you put up a ureteral catheter, and then you inject the Sonaview, and you can really improve your visualization of a non-hydronephrotic system on ultrasound. So the contrast-enhanced ultrasound had 168 patients versus conventional 166 patients, and they showed that using the contrast enhancement, you had higher stone-free rates, higher success of single needle puncture, and less hemoglobin loss. So you probably were able to see exactly where you wanted to go and use it. So I think that's an exciting update in our equipment. Something else I wanted to bring attention to is RetroPerk. So this was initially thought of by Dr. Winberg in 2012, and now it's become its own device. So this is basically endoscopic combined intrarenal surgery, where instead of doing access from the skin poking into the kidney, you actually poke out from the kidney. So you can drive a ureteroscope up to your desired papilla, and then you can use a puncture wire and poke out through the skin and then achieve through and through access that way for PCNL. So I thought that was a very novel way of doing things and something that was an innovative technique for urologists seeking to obtain their own percutaneous access. The final thing I wanted to bring attention to for PCNL updates is the Monarch. Now, this is a robotically assisted platform that we can use now for percutaneous epileptotomy. The controller is really something out of like a video game. The way you can drive the scopes and drive the system itself. So the benefit of this, I foresee, is the fact that their way of actually achieving access was done through electromagnetic guidance. So rather than fluoroscopy or rather than ultrasound, this is a novel way of doing it. It was examined by the group out at UC Irvine as well. They did a pilot study for 13 patients. It was successful in 12 out of 13 patients. The stone burden pre-op was on linear measurement around 3 centimeters, volume measurement around 1,600 millimeters cubed. Mean OR time was quite significant. It was 187 minutes, likely due to the learning curve of trying to set up this robot. The CT scans came down post-update 30, and the stone-free rates were lower than one would expect, but it was most likely due to learning and also seeing how it does. But they did note that with the electromagnetic guidance, this puncture into the desired calyx was very easy and done on the single pass the majority of times. So I'm very excited to see how this plays out with percutaneous epileptotomy in the future. And then finally, I wanted to talk about non-invasive stone treatments and updates. There's this new device out there called the breakwave lithotripter by Sonomotion. So your standard shockwave lithotripsy sends shockwaves and fragments stones up and breaks them apart. But the breakwave lithotripsy, which was previously known as the burstwave lithotripsy, uses ultrasonic propulsion to slowly comminute stones and really dust them into tiny pieces and allow for passage. This was recently reviewed for their first in-human international multi-institutional clinical trial, where they showed that fragmentation occurred in, so I'll back up and I'll first say that this is how it actually works. You have this applicator and you put it onto the patient and you identify the stone and then you provide treatment for 30 minutes. It does not need to be done under anesthesia. The patient could be laying there and then providing feedback. And you just keep the ultrasound probe on target for 30 minutes. The overall result was that 88% of patients had some stone fragmentation. Only 49% were completely stone-free. But, you know, this was one of the first ways to show that you can use non-invasive stone treatment innovation to actually treat stones and potentially move stones. I'm very excited to see how this further develops. But what they concluded was that breakwave lithotripsy minimizes the need for anesthesia and appears to be safe and effective non-invasive clinical therapy for kidney stones. The last one that I want to highlight is the Avio or Aerolift by previously known as the company Applaud, where they had a proprietary formulation of negatively charged microbubbles that they could put around calcium-rich stones and then apply enhanced lithotripsy that way. So there's more and more ways to help us treat kidney stones out there. and more innovation. I'm going to very briefly touch on minimally invasive surgical therapies for BPH equipment. Uh, there's this increasing demand for doing this. There's the temporary implantable prosthetic devices known as the iTind. There's the prostatic UroLift. There's the robotic water jet therapy. There's water vapor thermal therapy. There's the Optilim BPH. But essentially, men are trying to get treatment for their BPH, but then try to spare their sexual ejaculatory dysfunction. So I do think that there's a burgeoning need for myths, and there's a demand. There's absolutely a demand for these treatments. So I look forward to seeing how they continue to develop. I'm only going to highlight one of them that's up and coming. It's called the ProArt Omega. This is a newer thing that we're going to see at the Innovation Nexus at the AUA. They're in their clinical stage startup. It's a biocompatible transurethral self-embedding prostatic implant that you can put that's reported to be completely reversible and differs from prior prostatic stents because of their material to avoid calcification risks. So here's a rug where you can see placement of the device is able to kind of stretch open the prostatic urethra. So I'm interested to see how this plays out. Lastly, just talking about anatomic endoscopic enucleation of the prostate and all the acronyms associated with it. Essentially, the acronyms are all talking about what kind of laser or what kind of equipment they're using to perform this procedure. So one new equipment update is that Richard Wolf has created the Shark resectoscope. It's a newer resectoscope, 24 or 26 French. It has a ceramic tip, and it can seamlessly integrate with their offset nephroscope called the Morscope, and then also their morcellator. So this is a newer resectoscope out there that can help enhance anatomic endoscopic enucleation of the prostate. There's also smaller and smaller resectoscopes out there. There's a push towards miniaturization for AEEP, and they abbreviated it minimally invasive laser enucleation of the prostate, or MILEP, with either a slim or ultra slim resectoscope. There is 21 French Princess resectoscope and also a 22 French resectoscope by Storz, but this is all more limited by our need for morcellation because these working channels and outer sheaths can't accommodate offset scope that we need a 5mm working channel to actually perform morcellation. So on the horizon for prostate treatment, I just wanted to highlight two companies. Andromeda Surgical. This is actually a robotic surgical arm that you can control with essentially an iPad and actually use your fingers to do the whole procedure. And their goal eventually in the future is autonomous surgery. So I'm very excited to see how this further develops. The next one is Virtuoso Surgical, which is actually an endoscopic robot. And I have a video here from their website that shows how they can use endoscopic arms to dissect and do surgery. So I wonder how this may apply for BPH treatments moving forward. So I'm very excited to see how that plays out as well. But you can see here they're using it to resect bladder tumor, essentially. So that finally concludes our whirlwind discussion on updates in endoscopic equipment. There are a lot of acronyms out there, but hopefully I brought some light to understanding what technologies exist. There's just so much out there. We as urologists use lasers all the time, so I wanted to really highlight laser understanding, a little bit of more understanding of what the lasers are doing, so that we can better understand why there are newer and newer lasers and what they're doing out there. So I hope everybody was able to learn something, and thank you so much. Open this up for questions.
So, Perry, that was a fantastic talk. Very, very well done, extremely thorough. I had a couple of questions. One on the Air Force One. So how do we know what the true limit of pressure is? Like a certain pounds of pressure when you apply the access sheath, will you perforate the ureter such a percentage of time, or how do we, because everybody's ureter is a little bit different.
Yeah, so when you're at UC Irvine, they had a force sensor device, which they used to track exactly how much force was being applied when you placed the ureteral access sheath, and then they used that data to identify on removal of the ureteral access sheath, identify pulse injuries, and anytime you went above 8 newtons, you would have a pulse 3 injury. So then that's how they used that as a threshold. And then they were able to correlate that over to a cheaper device, which is really just a modified syringe, to be able to track your force when you apply the device. So I wonder, for teaching especially, how to actually gauge that feel of that force, how much force is really 8 newtons. Yeah.
It's really surprising that if it's that reliable, like reliably every time above this number you get an injury, why it's just not like mandatory in an access sheet, if we know that.
I think that's a great point and a great question for safety purposes, especially. Yeah.
And then the J-fill stent is, we've talked about this for years. Is it now available in the United States? Is it distributed yet?
I don't believe it is. When I reached out, they said they were still working on it. So that was we did talk about it a year ago. So I would be keen to see whether or not it's available now. But it was
Yeah.
through Olympus, I think, distributed.
Well, let me see if there's any questions from the chat here. We got a great talk, which I completely agree 100%. I did want to ask a question about the magneto laser. So it may have benefits with stone retropulsion. Do you think we'll see any benefits with BPH therapy, or will we have that charring effect that you see with TFL or thulium?
I think that the magneto laser, I'm excited to get our hands on it, but I think the fact that it can modulate the pulse duration so long for a holmium laser, lowering the peak power, would also allow us to get better hemostasis. I think there is a desire to be able to have a laser that can have that carbonization effect, because that would really help with hemostasis, but then also be able to change the setting so that you can perform your standard enucleation as well. So I think they were trying to merge the technologies of getting a holmium laser that is capable of doing the high-powered stuff and also the benefits from a TFL. So it's not really a TFL laser, but their idea is to be able to have two lasers in one with the pulse modulation.
Perfect. Well, I'm excited.
Very great talk. I have not used the magneto laser, but I was reviewing a manuscript for it. Sorry if my son is cooing in the back.
Yeah.
But it was kind of interesting. One of the comments was that when it's in the magneto mode, the maximum frequency, if I remember correctly off the top of my head, like 32 or 35 hertz. So I don't think you'd be able to do like an entire hole up on the magneto mode.
Yeah, so when I saw the magneto laser, it has the capability of doing virtual basket on one side and then magneto on the other, and they used magneto for hemostasis at 1 in 30, is what I saw. I also have not tried it yet, so I'm excited to see how it plays out clinically in our hands.
Well, I think in Europe they've had really good results with it. At least the Twitter videos look great, so, or the X videos. But I guess that the proof is in the pudding. So we'll see what happens with that. Anybody else have any other questions before we sign off? We're almost at the hour mark. Okay. Well, again, excellent talk, Perry. Great overview. I know I learned a lot, and we'll see what happens in the future with all these new devices.
Yeah, looking forward to it. Thanks
All right.
so much.
Have a great evening. Bye.